It's not a thinker. It's not really intelligent. It just picks out the next word. Now, it's very good at it because it's billions and billions and billions of words.
Hello, this is Zach with the American Journal of Healthcare Strategy, and you are listening to the Clinicians and Leadership podcast series, where we seek to empower clinicians from bedside to boardroom. I'm joined today by a very esteemed and accomplished guest who's served in our healthcare system in the United States of America in a wide variety of areas and industries. And so I'm very excited to welcome today Dr. Jay Anders. Dr. Anders, why don't you take a second to introduce yourself and tell us a little bit about your experience and how you got to where you are now?
Thanks, Zach, and thanks for having me. Um, I have been in this business quite a while and done several things, as you mentioned. I started out being a general internist in a multi-specialty group practice. Did that for 20 years, including administrative roles in that practice as president and chief medical director and things like that. I got interested in healthcare IT at that point in time. We were at the very forefront of electronic health records, and we were looking for some way, believe it or not, just to stop transporting charts across five or six different offices. So we had trucks and charts and things going everywhere and tracking systems. So I thought maybe it's time we look at some kind of electronic read-only system. And that's where it all started. I got involved with a company called Integrate, which provided that system to our clinic. Subsequently, came their medical director. In the process of doing that, I also did a stint at Coventry Health as one of their medical directors. That's on the payer side of the fence. Um, was the CMO of Integrate, CMO of something called Mid 3000, which was a billing company primarily, but they also did electronic health records. They were purchased by McKesson, um, and I became their chief medical officer of their business performance services division, which was again a more billing and the electronic healthcare stuff. Then I came to Medicomp. I've known Dave LaRoe at Medicomp for now almost 20 years. We've collaborated back and forth. His product was actually in our old Integrate product years and years and years ago. And I've always liked what Medicomp has done. Very fascinated by their technology, and I've been working with them now for the last 11 years. So that's kind of my short story.
Well, and I'm just thrilled to have you on today. I mean, you've just walked through briefly just your experience and the wealth of experience and knowledge that you have. And I'm something that was really interesting to me just looking over your resume prior to this meeting was into this interview was your involvement in the information technology sector of healthcare from since the 2007, since the earlier 2000s. So you've been involved in the information technology side of healthcare for quite some time now. And fast forward to 2025 and the prevalence and presence of AI and artificial intelligence becoming more and more integrated into healthcare. I'm interested to hear your perspective on how you see the role of clinicians evolving as artificial intelligence becomes more integrated into healthcare.
That's a very good question. One of the things that's come out recently, if you read all the, I'm going to call it hype, most of it's hype, about what AI is actually addressing in healthcare right now, it is trying to actually outdo clinicians. And what I mean by that is they can take tests. The AI can do a test better than a medical student can, better than a resident can, better than an attending physician can. Um, but I will say this, the practice of medicine is not taking a multiple choice exam. It's a wholly different thing. So, what I see the clinician's role in all of this, and I think this is not going to end. If it does, it will be a very sad state for American healthcare, I believe, is that clinicians need to oversight these systems that are being created. And what I mean by that is the human is the one that actually is going to take the responsibility for the care of that patient. I'll give you an example. So, a woman comes in and she's got a breast problem. She's got a bleeding nipple. Okay, that's something's very rare, actually. I've read all these wonderful stories about how AI can augment breast exam and imaging analysis and all of that. But what happens if they miss it?
Mm,
What happens if AI is wrong?
mm,
This is something that's not seen very often.
yeah,
So you're going to have humans involved to try to oversight that AI input or augmentation. And that comes basically at almost every level. So
mm,
I see the clinician's role is to using it as tools where the tools are appropriate, and then oversighting it because the rubber finally meets the road with the clinician and the patient.
I think that's a great point, and just and speaks to just the importance of having someone with that clinical experience in exercising oversight over new technology and tools and artificial intelligence to recognize and to promote proper usage in there. And it should make jobs and lives easier, and not complicate it further. And that's kind of a delicate balance that's hard to find, especially in new, as technology is innovating, and there's new things that are being implemented, and without experience, someone may not know how to implement those effectively. And so I'm curious as well, kind of going off what you said. You answered this a little bit, but I want to hit on home a little bit more on it. Is in in a world where data, algorithms, and technology, especially in healthcare, can often overshadow the human element and the human component to healthcare. How can the clinician leaders ensure that artificial intelligence, AI, enhances rather than diminishes the patient clinician relationship? How do we prevent artificial intelligence from how do we ensure it's a bridge between the patient and the clinician, not a barrier?
That's also a very good question. One of the things that has been talked about recently is these medical chatbots that are actually, they think, could actually start to make decisions on their own regarding patient care. Well, again, it goes back to the responsibility and algorithms, guidelines, all of those things have been around for a very long time, long before ChatGPT ever poked its head up in the world. So people, patients, are not algorithms. They are a person. They have their own specific makeup. When you take that interaction between the physician, clinician, and the patient away,
Mm,
that goes away.
mm,
And I will tell you this, in all my years of practicing, one of the things I learned a whole lot about folks just watching them walk from the waiting room into an exam room.
mm,
Just that particular observation. There is very little way that particular type of art of medicine will get into an AI system. I'm not a Luddite, but AI can, what it can do is it can augment when physicians have questions
mm,
or they think they need to know something else.
yeah,
So it's like having a medical library at your fingertips if you
mm,
ask it the right questions and it gives you the right output. There, we'll get into that, I think, a little bit later.
yeah,
But as long as you can trust it, it will actually augment your ability to care for patients. When somebody comes in with a low grade fever and a runny nose and a sore throat, and I take a look at them and I do a throat swab, I don't need AI to help me with that.
right,
I can treat that patient without ever going to a computer.
yeah,
So we've got to kind of worry about or think about where and how much and how it gets poked into the healthcare continuum in the treatment of patients. And I think that's a big concern.
Well, and I think you describing it as a medical library at your fingertips is something that is attractive to any physician or clinician is taking care of patients, is having the opportunity to be like, hey, I've got access to this resource right in front of me. If you describe it as a medical library, yet when you describe it as, or when you mention artificial intelligence, sometimes that's met with this skepticism. And you may have some individuals in the over the across the medical field that are quick to introduce new technology and artificial intelligence as a tool into their practices, and you may have others that are dragging their feet, that know how they have functioned over the years and it's worked really well for them, and they don't want to introduce artificial intelligence, or even more so are skeptical of artificial intelligence. And you mentioned a key word in your last answer, just if you can trust it, if you can trust artificial intelligence, that's a key thing. So I'm curious to hear your perspective on how can a leader, how can a clinician leader, how can a physician leader foster a culture of confidence and competence around artificial intelligence while addressing those valid concerns, whether that's concerns about accuracy, concerns about bias. How can you foster that culture that uses AI as the tool that it is?
Well, a lot of that will come about when AI is more consistent and more uh, able to be trained well with data that is trusted data. So all of these systems are trained on data. And you've got to trust the data you're giving it to actually give you the output you want. The problem right now is that AI, and I'll back up and give you a definition of what an LLM actually is. It is a program algorithm that predicts the next word. That's what it does. That's all it does. It's not a thinker. It's not really intelligent. It just picks out the next word. Now, it's very good at it because it's billions and billions and billions of words, but it really doesn't replace valid clinical data being fed as training for these things because we have that. And there was an article in the last 3 months where 50% of the medical devices that are incorporating AI are trained on artificial data. Artificial. That means some other computer thought it up.
Mm-hmm.
That right there, that statement right there, if you put that in front of a clinician, they're going to say, "What?" Because we've been reading studies, clinicians have been reading studies for ever since they started training. You get a drug study, you get studies you have to read and discern. The same thing goes with AI. You can read it, but you have to discern what it's telling you. And if it gives you something completely off base, you've got to be able to recognize that. The other issue is those systems are very, very good at convincing you that they're right. So as long as we keep perspective that this is a big ball of information out there that can be accessed in certain ways, trained on real data with real patients in real situations, and intermediated by a clinician, that's where I think it's going to end up and where it should end up.
Well, and you also just you mentioned the skill set that particularly your physicians have to develop on reading a study, reading and evaluating data, and letting that drive their decision. Not just taking a study at its abstract and agreeing with the conclusions, but reading through the actual data and the process, and then evaluating that. And I love how you just take that and you apply it directly to implementing AI. Is you're not we're not just blindly trusting what it says, but we're verifying and we're evaluating its process, and seeking to have that verification. I think that's a great way that physicians, and particularly physicians, but other clinicians, can use this skill set that they're already developing over the course of their careers, and apply it in a different way. So something that something we've heard a lot about is the capability of AI and technology to assist hospitals, healthcare systems in meeting quality measure compliance levels. Um, I'm interested how can there it is a tool, like we've said. How can AI technology assist not just in meeting those measures, those levels, but redefining what high quality care looks like? Do you see capabilities of AI in implementing in those ways?
I do. To break it down just a little bit, quality measures, are kind of a surrogate for quality care. That's there. If you follow the measure, you should be doing quality care. So let's put that on the parking lot for a moment. One thing that AI can do is go through a lot of data and organize that data for you because quality measures really should lead to better care, which means you have to do something as a clinician to make sure you've met the measure, whatever, and then make sure the patient's okay with it. One of the downfalls of LLMs right now is they're not very good coding machines. They don't know the codes. And if you look at what a quality measure actually is, there's a numerator and a denominator and a whole gob of codes. So you've got to be able to really discern not only what the clinician's doing, but the coding behind it. So if you take just a regular old text note and you're trying to move through that system, you got to make sure all that coding's correct.
Mhm.
So we're not quite there yet. But what I do see is that it can go through data and analyze, okay, this patient may have this that you didn't know about. You didn't see it. It's buried in this myriad of data in a health record. Oh, maybe I should pursue that. AI
Yeah.
is very good at doing some of those tasks.
Yeah.
The other thing I think we've got to keep in mind here is these systems when they first came out, everybody aimed it right at diagnosis,
Mm.
diagnosing care, doing treatment plans, all that stuff. There are a whole host of things in healthcare that AI can do that are not direct patient care.
Mhm.
Making sure facilities are scheduled correctly, making sure materials are where they need to be, anticipating how much of this or that you need to order as a hospital or a health system. So when you take it poking in AI in healthcare, there's a lot of low hanging fruit that doesn't directly impact a patient.
Right.
So why not vet these systems on their ability to do that kind of work before we turn them loose on something that's much more complex?
I think that's a fantastic answer. Particularly, just I mean, you mentioned just the all the benefits that AI and this technology can bring beyond just the diagnosing of a patient, and how that the diagnosing of the patient you mentioned is something that catches makes a lot of people pause, and is can be a focus of the skepticism that AI faces. Yet
Okay.
the ability of it to evaluate, analyze, and synthesize data in a very quick manner, and doing this with large amounts of data is a tool that can be leveraged really well and really effectively. And I think that you hit the nail on the head just in your answer there. So shifting gears a little bit, Dr. Anders, I'm interested, something that is long been an issue in the healthcare industry and field is this interoperability, and how that has just always been a challenge. And for those of you that don't maybe aren't familiar with that term, it's the ability of your software, your technology systems to exchange and make use of information. But it's this exchange of information of different systems, and using that information and sharing that information. And so I'm interested to hear your perspective on how clinicians and leadership and can influence, and what role they should play in driving standardization across systems that make these AI tools more impactful, more helpful. We've talked about how they can be impactful and how they can be used rightly. So, how do your clinician leaders, your physician leaders, and other clinician leaders, what role do they play in driving this standardization across these systems to make AI tools more impactful?
Well, first off, I'd like to congratulate the Office of the National Coordinator and Mickey Tripathi's crew, who have come up with some, I think, fairly solid guidelines on interoperability and how that whole system is going to work. One of their focuses right now, or has been, information blocking, meaning I'm not going to share my data because it might be something that's business proprietary to me because it's the big clinic down the street. And I'm not going to send my patients to the big clinic down the street because they might take them and take them away. And now I lose my patients. Um, that's been a problem forever. The thing about interoperability is when it comes down to it, if it is done well, you can save a tremendous amount of money in healthcare and you can get better patient care because you're not having to repeat something that's already there in a format that can be used. Big issue here. These things right now is it's like a fire hose. The hoses are there. They're connected. Water is flowing. But when you get, I'll use my old patients. I had patients that would have in a paper record 8 inches of chart. I mean, we're talking chart, big chart. How do I find what I need in that? I mean, it's impossible. There you go. That's what AI can do for you. It can sift through all that nonsense and say, okay, give me everything in there that is related to diabetes, provided it's trained on what diabetes is. So when it comes to interoperability, to enhance that is the usability of that data that goes from one place to another. Right now, like I said, the pipes are open and people are connected up and people are sharing things. But using that data after you get it is another whole story. And my fear is that physicians, when they get it, are going to say, I can't find anything here. I'm not going to read through 47 pages of PDFs. I mean, that's just not going to happen. So we got to really work on that part of it. So connecting it up, getting it exchanged, and finding what you need for the patients that's in front of you is the key factor.
And you've touched on this next question, and this is the last question before I let you go, Dr. Anders. So I appreciate your time today. And you in your last answer you touched on it a little bit, but beyond technology, what are some cultural or organizational barriers that must be addressed to achieve true interoperability in healthcare, and how can your clinician leaders tackle and address those effectively? You've touched on this a little bit, but I'm curious to hear some more of your thoughts on that.
Well, one of the problems we have, and if you want to roll back to the AI question for a minute and actually
Mhm.
sorting this data, that raises a specter of the social determinants of health and the social biases that some of these systems do have. Um, I mean, one of the things I would encourage leadership to do, um, we did it at my old clinic back in the paper days, is we never stopped anything from going anywhere. If you requested information, you got it. We didn't care about the business aspect, but we should have. I don't. My board did not poke against me on that. But today we've got to be able to share information across the board. And that means everything you have. One of the problems with the COVID-19 pandemic is the CDC could not get accurate information as to the spread of this disease. Why? Because people weren't sending, there wasn't the capability of sending that. So there's a lot of social and cultural aspects to that. The other thing, or one of my soapboxes, has been rural health. I kind of grew up in that part of Illinois. I spent a lot of times in emergency rooms at a 25-bed hospital. So I understand that delivery of care. These folks don't have a lot of resources to make some of these decisions. I mean, we have to start leveraging what we have, but there needs to be a funding mechanism for rural health so that information can actually get there. So leaders can work with other leaders to kind of get coalitions together. That's happening in my old home state of Illinois. It happens a little bit here in Pennsylvania, but not as much as I'd like. But where those people that live in rural areas can benefit most from this type of interoperability and type of connected care because they see their primary in a little town of 15,000 and they go to the big city and they see the specialist. And there's all kinds of things done. That's got to flow back into that primary care's office to really deliver the health care that patient deserves. So we've got to start really looking at the funding. We've got to start looking at the cultural cross connectivity in parts of our country. Nobody has a problem with the healthcare done here in Pittsburgh. We got two major centers, things flow all over the place, no big deal. You go out in central Pennsylvania, another story. So leaders need to step up and make their wishes known because if patient care is the top of our list, and it is, you still have to be a business, but if patient care is the top of the list, then we've got to start coming together and say, okay, how can we really make this work for everybody, regardless of your resources? Because the resources will grow if we can get the cost down and the care elevated.
Well, Dr. Anders, I'm grateful just for the opportunity to interview you today. Thank you for joining us on the Clinicians and Leadership podcast. I've greatly benefited from this conversation, and I know that anyone that has the opportunity to listen to it and take from what you have said and your experiences and your insights will benefit as well. And you at the end there, you spoke to the importance of just continuing having these conversations and working together, and the collaboration within our healthcare system is always critical, but especially when we're seeking to implement changes that are going to benefit the patient, which is the ultimate goal of any healthcare organization. Um, Especially in those rural areas, there needs to be advocacy and help done beyond just those rural areas. And so I'm grateful for you and your passion, and the way that you are seeking to encourage those kind of conversations. So thank you, Dr. Anders, for joining us today. And that is all I've got for you.
Thanks, Zach. I appreciate being here.